Hi there. Welcome to our third webinar in the Collegiate Recovery Leadership Academy webinar series. My name is Sydney Chaifetz. I use she, her pronouns, and I work as the Assistant Director for Student Development Programs within SAFE Project. So for those of us new to SAFE Project, what is it? SAFE is a national nonprofit organization, and we have four main initiatives. Our initiatives are Safe Communities, Safe Campuses, Safe Workplaces, and Safe Veterans. Simply for the sake of time, I'm not going to go into detail on what each initiative does, but I highly encourage you to check us out on our website at safeproject.us to learn more about what SAFE does and how we can partner with you. Today, we're here on behalf of the Safe Campuses Initiative, and the Campuses Initiative's mission is to normalize and promote recovery and reduce stigma on campuses across the country. We do this by providing support and technical assistance and opportunities to both students and staff from across the United States. So tonight, we're here on behalf of the Collegiate Recovery Leadership Academy, which is an academic year-long fellowship program for students in recovery and also recovery allies. These fellows work on impact projects throughout the year that impact recovery on their campus community. Additionally, they attend a handful of events like our annual summit and our spring retreat, and they receive mentorship, they receive training on topics of collegiate recovery and advocacy through many avenues, including this webinar series. So a little bit of housekeeping before we jump in with our spectacular speakers. If you have any questions throughout the webinar, feel free to use the question and answer feature, and at the end, we will get to everyone's questions. The chat feature is functional, so please continue to use the chat. I love to see that so many folks have already introduced themselves. Please introduce yourself, your name, what school or organization you're a part of, and why you're excited to be here today. So with that, I am so incredibly excited to introduce our two speakers because, as many of y'all have expressed in the chat, and SAFE knows so much to be true, harm reduction is such an integral piece in the work that we do. So tonight we are here with MJ Jorgensen and Brandi Drtina. MJ is a community catalyst, a substance use advocate, and a person in recovery. And Brandi is an advocate, a peer recovery specialist, and a person in recovery. So please use the chat feature to help me welcome MJ and Brandi.
All right, everyone. I see the chat blowing up. Thank you so much for welcoming Brandi and I into the conversation and into your learning series. We are so grateful to be here to really speak about harm reduction, but also speak about what it means to put it in practice. This is more than just philosophy. It is a set of strategies, and we're going to talk more about that today. To get us started, I think it's important that we introduce ourselves. Sydney, thank you. And we can add a little character there. So I'm MJ Jorgensen. I use they and them pronouns. I am the Director of Addiction Response with the North Colorado Health Alliance, which is right here in Greeley and Fort Collins, Northern Colorado. I get the privilege of working with an incredible team every day, bringing better access to substance use, treatment, prevention, recovery, harm reduction across the board. I also get the privilege of working with our Northern Colorado community partners and building regional networks around this work, bringing us closer to a state in which people can grow, thrive, and survive wherever they are in their spectrum of addiction. And I'm also a person in long-term recovery, and bring that level and lens to this conversation today. Have spent my entire career in substance use work, be it in syringe access programming, HIV prevention, LGBTQ efforts, systems work, policy change, all of that jazz. And so am excited to come to this conversation with you all and carry forward some new learnings for myself, because every time we have a conversation like this, I learn something too. And it's important that even as those who have been in the field, that we continue to learn, grow, and strive to do better, because that's what harm reduction is all about. So I'll let Brandi introduce herself.
Thanks, MJ. Hello, everybody. Welcome to this webinar. MJ has a really nice, wonderful, long introduction. Mine won't be as long, but I use she, her pronouns, and I am a certified peer and family specialist in the state of Colorado. So what that means is I get to use my lived experience to try to encourage others through their road of recovery, whatever that looks like for them. And I am also a newly promoted to supervisor role. So I get to supervise folks now who are working with folks in recovery. So I'm super excited to be here. And I think we have, like MJ said, we have a lot to cover. So I will go ahead and get started with our agenda. So today, what we're going to cover during this webinar is we're going to define harm reduction as a whole. So give you a good definition and talk about what the philosophy of it is and the goals of harm reduction. Also go into a brief history of what harm reduction, like a timeline of harm reduction events and what's brought us here today. Also talk about the necessity and the validity of harm reduction as a recovery strategy. And just talk about putting it into practice. When we're done with this webinar, we hope that you will have a better understanding of addiction recovery and the importance of lived experience in multiple recovery environments.
So as we move through all of this stuff today, which we have just an obscene amount of content to cover, as Brandi kind of outlined for you there, we're going to challenge you. We're going to test your values. We're going to test your beliefs. We're also going to challenge you to kind of reflect over these 3 questions in front of you as we move through the content. And so what can you do individually, organizationally, as a system to be more person-centered? How can you influence others to do the same? What's your role as an ally and an accomplice in this work to create change, create safer spaces? And what can be done? What can be done to increase access to compassionate care and harm reduction principles? So take these questions as we move forward and take them with you when you leave as well. So we're going to get rolling. But again, we've got a lot of content to cover. But that content is more valuable if you conceptualize all of it surrounding these 3 questions. So what is harm reduction? Harm reduction is a lot of things. Harm reduction is a set of philosophies. It's a set of strategies. It's the way someone engages with others. It is the baseline for many people in how they do this work being a number of things. The overall goal of harm reduction is, at bare minimum, let's keep people alive. That's the goal. That's it. With that, though, we know that there's a more formal definition, and this is the more formal definition that we'll give you today. And that is that harm reduction is a set of practical strategies and ideas. So we've got strategies and ideas here, and they're all aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief and respect for the rights of people who use drugs. Again, the goal is just to keep people alive. And this is the definition how we do that. With that, harm reduction has time and time again been proven to be at its core about relationships. This is a quote from Shira Hassan, who wrote Saving Our Own Lives, which is a new book that I highly recommend, that really talks about liberatory practice in harm reduction. But Shira says, I say over and over that harm reduction is about relationships at its core. It's a mutual aid model that places all activities from drinking coffee to violence to drug use on a spectrum of harm. The spectrum being, this is manageable, this is not manageable, this is chaotic, potentially for me. And says, okay, what do you want to do about it? And with that, I think it's also important that we acknowledge some of the principles of harm reduction that have gone back to originally being written by the National Coalition for Harm Reduction, or the mothership of harm reduction, as I like to say. And one of the key ones is that we accept, for better or worse, that drug use is part of our world. And we're going to choose to minimize its harmful effects rather than pretend that they don't exist and condemn folks to the corner rather than supporting them. So this is one of the key principles here. We accept it, good, bad, otherwise. And now what are we going to do about it? So some of the other principles of harm reduction, again, originally written and continue to be maintained by the National Coalition for Harm Reduction, include that we're not attempting to minimize that drugs are not harmful. In fact, harm reduction says, hey, there's this thing, let's reduce the harm. So if we were saying that drugs were not harmful, we would be missing out on our entire scope of work here. We understand that drugs are complex, that they look different for literally everyone. They're multifaceted. And with all of that, we're just working to establish quality of individual and community well-being. So that is at the center, right? We are non-judgmental, we are non-coercive. We know that judgment and shame, if they were going to work, they would have already. We wouldn't be in the situation that we're in. And one of the really big core principles of harm reduction is that we're giving, sharing, holding voice for folks who are directly impacted by this issue, and that those folks, we are in charge of reducing our own harm. We are the primary agents. What we want to do is what counts. Okay, and finally, it really acknowledges that all of this is enmeshed in social inequity. We know that the identities that we hold and the intersection of all of those identities impact the way that we engage in systems, the way we engage with each other and with ourselves. And so with that, let's make sure that, again, I'm the center of my change, and that change is held by me and moved forward by me. And if you want to come with, that's great. Okay, that's great. So the briefest of histories, these are some of the big points that have happened throughout harm reduction in the last 30, 40 years. There is a larger historical accounting in the back of these slides that if you've registered, I'll have Sydney send those out to you. So you can read up a little bit more. But ultimately, what we want you to take away from this brief history, the history in the back, is that harm reduction has a very complex history in the United States. And the USA is in this weird space where we've led the charge in developing some aspects of harm reduction, including medication-assisted treatment or recovery. But we've also been in this other side of things where we've been a fierce opponent of harm reduction from a governmental federal policy level, both domestically and internationally. And the history of harm reduction is best understood between this conflict of these opposing and multiple forces throughout history and even to today. So the two most important forces really promoting harm reduction in the US have been activism and research. The role of activism is overwhelmingly prominent in the harm reduction world. It is the base of its roots. You'll see in the 1970s column on the left of your screen that the Black Panthers and the Young Lords established the Lincoln Detox and Recovery Center. And that was as a result, actually, of methadone being pushed into the communities by federal governments and state governments as the really only solution to addiction. And the Black community saying, no, we want some additional options. We're going to do this our way, and taking up that space at the Detox and Recovery Center and saying, hey, this is ours, and the treatment of our community is based in our community. And if you have not watched the documentary Dope is Death. That is a great resource for you to learn more about the Black Panthers and Young Lords movement at the Lead Kid Detox and Recovery Center. Would highly recommend. But that's just one of the spaces in which we see harm reduction being rooted in liberation movements, in identity specific social movements. Additionally, harm reduction has a deep connection to the HIV and AIDS epidemic, and the ways in which the community of folks who are engaging in sex work and those engaging in drug use were saying, hey, this thing is happening. We got to support each other. We got to show up for each other. And with that, they developed their own community spaces. They developed their own advocacy arms around access to medication for the LGBTQ community. They said, we need access to unused syringes and paraphernalia so that we are not transmitting HIV and other diseases to each other. And so with that, we actually saw the first syringe access programs pop up in the Netherlands, and also the first one in the US pop up in 1988. And that was over in Washington, in Tacoma. And that is because of the movement of those folks who said, we're done with this. This is enough. Our community can do better for itself if you just let us, And so with that, we continued to see advancement into the 90s of legal statuses of syringe access programs and other harm reduction services become more validated throughout the nation, validated in a legal sense, from legal, illegal, but tolerated, absolutely illegal, we're ticketing you for this, and illegal and underground. There have always been syringe access programs. It's just whether or not you knew about them, whether or not they were legal, all of those things, right? I started, some of my public health journey was in a syringe access program, and I was reminiscing with some of the folks who were there in the early days, and they said that they would leave syringes in a drawer and leave the room. They did not exchange those needles. They were just found in a drawer, and that person would leave that site with the things that they need. And so people can get more creative than the issue. And that is the root of harm reduction, is getting more creative than the issue. Regardless, many harm reduction interventions like these started out in grassroots spaces by people who use drugs, for other people who use drugs. And it is in response to a lack of support or a lack of resources for communities that these things have cropped up. These concepts have spread nationally. There is still so much work to do to increase access, increase advocacy and legislation of changes, and contribute to a better spectrum of care, better spectrum of health for people who use drugs. With that, we have seen that medical and public health authorities have largely been a little bit slower to adapt these things than harm reduction grassroots orgs. Not a big surprise there, but these are all based in evidence. And despite all of this evidence, we're still getting told, no, our community is not ready for that. No, we need to do X, Y, and Z before we move into those radical strategies. But throughout the history of harm reduction, this has been a political and social movement, but it's been driven and put into practice by people who are directly impacted. And that is both the folks who are using drugs and also those folks who are boots on the ground, those allies. I see you on the call. And those allies in this work are just as critical to moving these practices forward. The health workers who were in the hospitals during the HIV epidemic, those were those allies. And again, the work is not done. There's plenty to do. With that, when we move into the times of today, We're still seeing, and we'll talk more about this, that syringe access is still not largely accepted. Naloxone still has barriers thrown up. We don't want to talk about drugs that will make drugs happen. These are things and narratives that we hear every single day, even in an arguably more progressive state like Colorado. And so these setbacks still remain. Drug policy is shifting constantly. We've seen a lot of policy recently that really is hunkering down on drug accountability laws, and it's continuing stigma more than it is progress. And that's where all of this work comes together into how we practice today. So to elaborate more, harm reduction is not only tied historically, but presently to these movements that are listed for you: the Black Liberation Movement, HIV/AIDS rights movement, the LGBTQIA movement, health revolution movement, women's justice, disability justice, and why. These movements are all tied to harm reduction because they are all community-based. They are relationship-based, and they're all saying we're missing out on access to safer spaces for ourselves and for our community, for our nation as a whole, and we're going to do something about it. And that's what harm reduction does. So, Brandi, I've been jabbing for a while.
Yeah. Okay, so I'll give MJ a little break. So can any of you guys think of some examples of harm reduction? If you'd like to throw those examples in the chat, that'd be great. I'll give you just a couple seconds, well, maybe a minute or so, to throw some of those examples into the chat, and then we'll talk about harm reduction strategies and principles. Yes, reducing use, Suboxone. You guys are so smart. Everybody knows what harm reduction is, MJ. Yes, go low and slow. Perfect. Have a plan. Those are all really, really great examples. Don't use alone. I love it. Okay.
Yeah.
Okay. So yeah, all of those things are great. Ooh, seatbelts. Even some non-substance use related forms of harm reduction are being talked about. Airbags. Yep, love it. So yes, harm reduction as a whole is just a way to reduce harm, right? So a lot of these on this slide you're going to see are all around our substance use examples of harm reduction. So we have syringe access programs like MJ was talking about. Those are going to be harm reduction around reducing the risk of HIV and Hep C, as well as other infectious diseases. Policy change, which I think MJ will talk briefly about in a little while. But basically, you know, there is some harm around policy and in the laws that are put out there. So basically advocating to make that policy change, right? And then we have medication-assisted treatment, which a few of you mentioned in here. That's a really great form of harm reduction. So that's going to be medications that are safer to take than illicit drugs, and then combined with some other therapeutic techniques like group therapy, individual therapy, visits with clinicians, things like that. Safe use sites. Basically takes away the danger of overdosing, right? And like you guys said, not using alone, right? So having a safe place to be when you are using, and then also kind of reduces that risk of infectious diseases as well, from not hanging out in environments that could be risky. And then naloxone or Narcan, a few of you guys mentioned that as well. That's one that we promote quite a bit here. We do a lot of naloxone trainings, advocating for folks to be able to carry it. And so it is a medicine that's completely safe and easy to use. And all 50 states actually have some form of naloxone access, but also laws around naloxone. So there is going to be appendixes and resources at the end of the webinar that you guys will have access to find more information out about that. Peer support, peer recovery and support, which is my favorite because I am a peer support specialist. So that's just people with lived experience, hanging out with people with lived experience and walking alongside them. And so basically kind of keeps, it helps with mutuality and the reduction of stigma and all these really great ways to help people who are looking to get into recovery. And so moving on, we have fentanyl testing strips. So a way to check the presence of fentanyl in other drugs. And then, yeah, you guys talked about reducing use. That's another one. If you can move from using 10 times a day down to 5 times a day, the risk of overdosing and the risk of being in that risky behavior reduces. So those are all really, really good examples of harm reduction you guys named. So with keeping that all in mind, these are the strategies behind all of those harm reduction examples. So we want to keep it person-centered, right? What works for somebody, they get to decide what works for them, not what somebody else says works for them. And it's non-coercive, so we're not going to force them. They shouldn't be forced to do something certain ways. And then also supporting and not stigmatizing, so not passing judgment on them. And then it's also based in empowerment. So again, kind of working off their strengths and what works for them is really what harm reduction focuses on. And then last but not least, it's based in body autonomy. So, what I want to do with my body is what I want to do with my body, and nobody else can tell me what to do with my body. So, okay. So this is an example. This is a moment for us to pause and think through this small exercise. If you can imagine that you have a superpower, any kind of superpower that allows you to freeze time. The key descriptors that cannot be changed are the age of the person, the drug or situation, and the location of the activity or event. You do not have the ability to change anything about them, like their age, gender, race, etc. Yet you do have the ability to freeze that time and add a useful tool or an idea that will increase the likelihood of someone staying safer. So you guys are going to have a couple minutes to think of this. And in this scenario, this person is actually going to use an unknown substance in a campus restroom. So now you have to think of a superpower that you have and a useful tool to help keep this person, this human, in a safer environment. And you can feel free to throw that in the chat if you want to. MJ, do you have a superpower?
Well, my superpower would be to freeze that moment, right? And I think I would zoom in and be present and check on them after they were done using.
So maybe I think mine would be like invisibility. And so that way nobody could stop me from going in there to help them, right?
Right.
So, okay.
Heather says new equipment.
Yeah, you guys got some great ideas. Great superpowers.
Yeah. Sandra would stay with them and give them the tools they need.
Yes. Yes, I love it.
Would have naloxone.
It's amazing.
I would test the substance.
I love it.
Yeah.
Okay.
Yeah. Awesome. Awesome.
Yeah, you guys did great. You guys did great during that exercise. So I'm glad that all of us have these superpowers, because we do really have all of these superpowers, right? So I'm going to go ahead and let you go, MJ, for just a moment, and then I'll take back over.
Yeah. So all of the examples y'all named have a lot of evidence actually to back them. And we want to just kind of cover all of that. But really the summary of these next, 5 slides is that it's all best practice. And it has been for so long. And you as harm reductionists, we as harm reductionists have to have these one-liners, data points kind of in our back pocket when we get met with stigma or resistance to some of these strategies. And so that's why we thought it was important to incorporate some of this today. These slides are heavy. There is a lot in these slides, and we're going to do a quick summary, high-level overview of them. And again, you'll have access to these, but for supporting folks with disabilities who are not auditory processing folks, there's a lot more content on the slides to support in that way. And also, because this is a big topic and we got 50 minutes, so.
Thanks, MJ. Okay, so yeah, so we're just going to talk about some of the outcomes of compassion here. I have a couple to chat about. So the first one is peer-based services. Basically, peer support is evidence-based, and it shows that peer support or recovery coaching helps reduce all of these things kind of listed at the bottom, like the relapse rates, also increase treatment participation and retention, and then also improves relationships with providers. So basically letting the provider do what they need to do with the continuum of care, and kind of keeping the relationship building and the skills building to somebody who's been there, done that, right? So peer support's amazing. The role of a peer support or peer recovery specialist is to really just act as a mentor and guide by providing a range of services that includes instrumental, emotional, informational, and affiliation support. The next outcome of compassion we're going to talk about is naloxone and overdose education. So this is something, like I said earlier in the slides, we do a lot, right? So naloxone, there's evidence that shows that naloxone there's programs for naloxone, and access to naloxone prevents overdose fatalities and does not enable use. So there's evidence that goes in that shows that it does not enable people to increase in more risky behavior or things like that. Naloxone distribution programs connect people who use drugs to other necessary services. And then community-based naloxone distribution programs are widely supported. So the ones that are listed here are some of the main ones: the American Medical Association, American Society of Addiction Medicine, the Office of National Drug Control Policy, U.S. Conference of Mayors, American Public Health Association, and the United Nations of Office on Drugs and Crime.
Yeah, to continue this narrative, right? Syringe access programs, also best practice. And so nearly 30 years of research have shown that syringe access programs are safe, effective, save money. They don't increase illegal crime or drug use in your community. They reduce transmission of HIV, hepatitis, bloodborne pathogens, endocarditis, wound care needs, emergency visits. All of these things are backed by research. And folks that enter a syringe service program, syringe access program, are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs than those who don't use the programs, right? Holy cow. Holy cow. And why? The question is why? And it's because syringe access programs are based in relationship. They're based in relationship. They're based in hard conversations. They're based in that peer-to-peer engagement. This is why these things work. It gives people a space to engage in a conversation about their health, that they have largely been taken out of that capacity by so many other providers, that this is the spot that they can have that conversation. Wow. Okay. Syringe access programs largely at this point in time are also coupled with naloxone overdose education, and additionally reduce overdose death, right? They also protect the public. They help with safe disposal of syringes. The data also says that this does not increase litter, paraphernalia-based litter. And so giving someone a place to put their used works is a critical asset to a community. Also, gives folks the education they need on how to have a conversation with a first responder if they do have sharps on them, and how to handle that situation. So here is just a picture of what drug paraphernalia laws look like in the United States. So the yellow is there is no drug paraphernalia law, so no one's getting in trouble, but no one's also protected necessarily by the law. Orange is no prohibition against possession of paraphernalia generally, right? Might still pick up a charge here and there. No prohibition against paraphernalia for personal use is that light orange. Blue is needles and syringes are not part of the definition of paraphernalia, so you can still get charged for literally every other part of your HIT kit, right? Your cookers, your water, your straws, your tutors, all of that, not exempt. Use and possession of needles and syringes allowed for folks under the age of 18. Use and possession of syringes allowed for folks only those who are engaged in syringe service provision, so SSP or syringe access programs, SEP. You'll also see exchange programs, so that's the green. And definition references needles and syringes, but has no exceptions to that rule. So you can see that the nation is in this kind of, we're all taking this on a state-by-state basis, right? And with that, we see a lot of folks moving and getting caught up in a different state's policy and uncertain of their rights in those states. And so that also provokes the need for us to continue to advocate for syringe access programs, knowing how wildly effective they are to be more available nationally. So safe use sites, we saw that get dropped in the chat, or safe consumption sites, safe injection sites. In Colorado, we are in debate on this one. That piece of legislation was introduced about 2 weeks ago. Regardless, more than 100 evidence-based studies have consistently proven that these are good for communities. And so here we are again, syringe or safe use sites increase entry to substance use treatment, prevent overdose death, reduce the amount of and frequency that folks are using drugs, reduce public drug use and syringe and drug paraphernalia litter, reduce HIV, Hep C, and are a massive cost savings for our healthcare systems. So what's the question? Because I've got the answer, right? We've got the answer here. We also see that increased entry into treatment. We also see that folks are just able to receive the things that they need. That's exactly what these are for. The one that's being proposed in Denver would be coupled with medical staff, treatment staff, and in no safe use site internationally has someone died from an overdose. In no safe use site has someone died from an overdose. Okay. So another strategy, we've got medication-assisted treatment, medication-assisted recovery. Again, decades of evidence demonstrates how effective this is. We're cutting overdose rates, we're decreasing substance use, we're improving quality of life, and decreasing crime rates all in one foul swoop here. What's really disheartening about medication-assisted treatment is how many barriers have been put in place to keep this from being accessible. I got a call from an urgent care a few weeks ago that said, no, we don't do that here, as far as giving someone a continued script for their buprenorphine, not even starting them on a script, but continuing their prescription. And that is where we're at. Right? That is where we're at. So what does it take, right? Knowing that only 1 in 3 treatment programs actually offer medication-assisted treatment nationally, 1 in 3, 33%. With this data, the behavioral health world isn't even there yet. So what will it take? So drug checking, we're talking about fentanyl test strips here, right? Strips are inexpensive. They're $1 a strip for us in Colorado. They're easy to distribute if you have that continued access. these also are evidence-based. I can't emphasize this enough. Research in Johns Hopkins found that 84% of people who inject their heroin were concerned about fentanyl in the drug supply, right? What's the answer? Let's give them some test strips so then they can actually make a consensual choice about the drugs that they consume. Additionally, 86, same study group, 86% would check their drugs for fentanyl, and 70% of those who checked would maybe use some harm reduction strategies to make that situation safer for themselves. So injecting more slowly, not using alone, having naloxone present, phoning a friend, all of those things, doing a tester shot, those types of things. And these are folks who are using drugs, responding to these surveys. The stigma of it all, the narrative we hear in the community is that folks who use drugs don't care about their health. And that's just not true. It's not true. We know this. It's not true. We have to break the stigma. We have to break the stigma. So, Brandi, it's you.
Okay. So how do we engage harm reduction as a philosophy instead of strategies in our work? I think these next few slides, we're going to talk about what we do here at the North Colorado Health Alliance. So we'll kind of skim through these slides pretty quickly. So that way we can save some time at the end for questions and answers. We have about 8 minutes. So I hope all y'all are still with us here. So the North Colorado Health Alliance, which is where MJ and I spend a bulk amount of our time during the day, right? We are a collaborative for addiction and recovery supports, and underneath or as part of all of these strategies that we do our work in is all under the harm reduction umbrella. So as you can see, like harm reduction is kind of up there at the top. So underneath a harm reduction, we practice prevention, treatment, as well as recovery. So under prevention, we raise awareness by helping to reduce stigma. We try to prevent overdose. So go out there and advocate and help agencies understand the importance of having naloxone access, and then training folks on how to use it. So super important. Under the treatment umbrella, we improve access to person-centered treatment through care coordination that is doesn't matter what type of payer source they have. So we are 100% grant funded in the addiction response team. And so we can help people regardless of what type of insurance they have, even if they don't have insurance. And that just really just improves care access points as well as with the criminal justice and health systems. And then our recovery umbrella, again, my favorite part is peer support. So we do peer-to-peer support. We help people get into access or get access to treatment. Also, we do some recovery coaching and then help them get access to support group meetings and help facilitate those as well. So the North Colorado Health Alliance. Within that, we have a network called Coleslaw. MJ always jokes that that's not our barbecue side, right? So Coleslaw stands for the Colorado Opioid Synergy of Larimer and Weld County. We've outgrown our name. This is just a network within our addiction response team that helps people get access to medication-assisted treatment and free care coordination. We've outgrown our name because we support all substances, not just opioids. And then we also have grown outside of our Larimer and Weld County areas. We have some support that spans out east of into the rural communities of Colorado. And so, yeah, so we'll go ahead and go to the next slide, MJ. How do they get access to us? So there's a couple of different ways that they can get a referral into us. This toll-free number goes directly to MJ's phone. So MJ gets that and puts in a referral to one of our care coordinators or peer support specialists. And then we contact the person back and start working on what recovery looks like for them, and building that recovery plan with them. Also, they can gain access by utilizing this web referral form on the left. So a lot of different ways we receive our referrals are from the community, from jails and hospitals, as well as community members. If you'd like more information, you can also visit our website at the North Colorado Health Alliance. MJ, I'm going to go ahead and let you take over.
Yeah, so part of that collaborative network that identified, like, we got to work in prevention, we got to work in treatment, we got to work in recovery, all of those need to be harm reduction at its core, said, oh, well, since we're working in harm reduction, let's build an additional working regional group called the Northern Colorado Harm Reduction Alliance. So NOCO Hurrah, NOCO HRA, whatever you'd like to call it. That group of folks is a cross-sector partnership, and they've really said, these are the 4 areas that we want to work on. Peer support, network development, increased access to harm reduction strategies, education and community outreach, and policy and advocacy. With that, policy and advocacy looks like having awareness, education around the policies and pieces of legislation that are going through at the state and at the federal level, making sure that our organizations are equipped with all of the information they need to take a stance on those pieces of legislation, and also looking more locally, what are the policies on the city level or the municipal level that are keeping us from having harm reduction strategies in place, or even the organizational level, what policy changes need to happen to do contactless distribution of naloxone, for example. Additionally, we do a lot of work around education and outreach. Brandi referenced this a little bit earlier, but this is overdose prevention. This is naloxone education, fentanyl test strips, stigma reduction. We do that with community organizations, provider networks of all stripes, our general population as a whole, our education sectors, so our universities, colleges, and our high school and middle schools. And then we also work with medical providers in our behavioral health sector to make sure that when folks are showing up at the door, that they are utilizing harm reduction strategies as well. That harm reduction is not just sitting in this one special place, even though we need that special place in the syringe access program, but that our providers are people-centered, trauma-informed, strengths-based, and empowerment-based. They are non-coercive. These are all the practices that require community education and outreach to those providers to be engaged, to be embedded.
Okay. So glad you guys are all still with us. We got a couple more minutes left as we wrap up. Just continuing on with our strategies from NOCO Hurrah is increased access to harm reduction strategies. So again, naloxone distribution, including contactless distribution. So we do have some vending machines that have some Narcan and some also fentanyl testing strips in them. We are going to be putting out some kiosks. They're going to be planted all over in the community. We're not quite sure exactly where, but with, probably outdoor and indoor, where people can just go and open up it looks like the old newspaper little distribution boxes where you can just open it up and pull the newspaper out, where you're going to be able to do that and pull your Narcan out. Access to fentanyl testing strips, advocacy and support of syringe access, and then also street outreach. So we're going out there, we're hitting the tented communities, we're handing out our business cards, we're giving out harm reduction supplies, and continuing to make contact with those folks, helping them when they don't have that real consistent access to care. And then peer support and network development. So we're expanding our workforce, right? We are doing the initial peer training opportunities for folks. So we have currently some free classes right now where we're getting some folks the beginning steps of recovery coach certification classes in. And so that's a really great opportunity to get some folks in there and get that certification process started. We're also doing an expansion of professional development, which includes leadership role. So myself, I got to move into a leadership role, which was fantastic. And just being able to mentor other new peers and helping expand that workforce, and then also just getting peers to be placed in really creative and new areas for harm reduction, treatment, and recovery settings. So for myself, I'm sitting at the day shelter where, some people who are unsheltered are receiving services. And so we kind of hang out there and talk about harm reduction and access to treatment and things like that.
I can't emphasize this enough because Brandi won't give herself enough credit and the team won't give themselves enough credit, but peers are incredible, and such an asset to any organization that has them employed, but also any organization that Brandi and I agree to drop one of our awesome staff into. They are the heartbeat of our team. This is another quote from Shira Hassan. One of the most important principles is that harm reduction is a peer-to-peer model led by those of us with stigmatized life experience. And liberatory harm reduction means that we're all teachers and we're all learners. And that is what this work is about. So with that, we're going to make you jump in the chat one more time before we move into questions and all of that. What are the ways that you see your community practicing harm reduction? We gave you a lot of examples, and that's definitely not all of them, right? We didn't go through all of them by any means, but hop in there, tell us what's going on. Working to be a peer certified specialist, very cool. Way to go, Edith. Distribution of naloxone and fentanyl strips. Good job, Ben. Narcan distribution. Thank you, Michelle. Jamie's hitting the streets with more volunteers, talking to more community outreach programs. Excellent. Excellent. Free naloxone. Awesome, Michelle. Yeah, if it doesn't exist, Sandra, what can we do to change that, right? Awesome. Awesome. So we challenged you at the beginning. We're going to challenge you at the end before we move into questions. Keep dropping those examples in the chat. You're helping your friends, your colleagues, your mentors, your shared folks. What can you do to be more person-centered? Even if you've got harm reduction services, what would take it to the next level and make them more person-centered? How can you influence others to do the same? So Sandra, if you build that thing with that neighboring community, what would it take to bring it next door, right? What would it take? And what can be done to increase access to compassionate care and harm reduction practices? So again, that's your challenge to leave today with. With that, we will move into our Q&A component. I'll stop sharing my screen, maybe. Sydney, what would you recommend? Should I leave it up? You're muted, bud.
Of course, that always happens. Thanks, MJ. Let's leave it up just for a couple minutes so that folks can jot down your contact information, because I'm sure you're going to have many people reaching out. But friends, that was absolutely spectacular. I've worked in this field for a while, and I am continuously amazed by the work that you both do and your ability to teach all of us about harm reduction and the ways that we can get more creative than the problem. So friends, please continue to plop questions in the chat. Let's collectively pick MJ and Brandi's brains because they've got a lot to share with us. So I see a first question answer here, if I'm just going to throw them at you. Kathleen says, our team does a lot of education to combat stigma on our college campus, but targets mostly students who are in recovery and aren't seeking recovery or aren't using substances in high-risk ways. Can you give a few tips for incorporating harm reduction and stigma reduction in peer support work, whether that be in coaching or in peer-based meetings?
I guess I can go ahead and talk about that one a little bit. So, for me, I have found that my work really lives in having myself kind of in a balanced area where I'm helping folks who are in risky situations all the time, who are still using and who might not even be ready to get into recovery, as well as people who are in long-term recovery, right? And so being successful. And so continuing to advocate for, that peer recovery work. We do support groups for folks who are still using. We call those support groups safer. And so just trying to, encourage folks how to use safer and in other ways. And then, we also refer people to mutual aid spaces. like NA and AA, where people are more abstinent, right? And so, and then we also have these support groups called CRAFT, and that's for really the family members of loved ones that are struggling. So that's kind of the spiel I have on that. MJ, do you have anything to add?
Yeah, those are all super helpful, Brandi. And I would just add that a lot of that stigma within folks with lived experience is internalized. We've all got our own stuff. We all got to work on it, right? So we can't make that internalized stigma about us if we're in that space of facilitation. But those things take time and a lot of seed planting and a lot of energy. And I would encourage you to both take time for yourself to make sure that that's not beating you down, but also give that person the grace that they need to work through their own internalized stigma.
I love it. Okay, I'm going to grab some of these questions that I see in the chat, and I'll try my best to go back through and get through all of them. But I see from Michelle, any best practices related to polysubstance treatment? For example, a person receiving Suboxone who is using cocaine regularly.
Yeah, absolutely. And it looks like Brandi wants to answer too. So we'll work together on this one. So we have various medication assisted treatment providers. They all have different entry points of care, right? Some of them are like, no, if you're doing Suboxone, that's all you're doing. But let's work on the policy around having a positive UA for something else, right? So maybe they increase their strikes or something to that effect for a higher barrier behavioral health provider. That said, we also have providers who only test for Suboxone or methadone, be it whatever medication they're using. That said, I always say shoot the gator closest to the boat. And if that person is willing to work on their opioid use with medication assisted treatment, they are safer that day than they were before. So that is a win, even if they're still using that stimulant. Brandi, what would you add?
That was pretty much everything I was going to add, but just to kind of spin off of that, this person who's using cocaine regularly, there really is no FDA approved medication that helps with, or that has been designed for stimulant use, but there are some creative ways that providers are introducing some other forms of MAT treatment. I think MJ, you kind of touched on that a little bit. So if this person is interested in trying to reduce their cocaine use or stimulant use, there are some things that at least are being done here in Colorado and in some other states that could be looked into. And another thing, just kind of to talk about some other types of treatment, is contingency management's another one that has been proven to be successful and is kind of newer in the harm reduction world. So.
I love it. Of course, we have more questions. I'll just note, friends, I've put a couple of links in the chat, more info on additional webinars, the Collegiate Recovery Leadership Academy. Take the survey so we know how much you loved the training, or give us feedback for the next training, more information on Safe Project and more contact info. But with that, I see an email here from Jamie, and I'm going to couple it with an email from Sandra. So it says, I'm working with someone in my area with the United Way for a needle exchange, but she has to do it underground, AKA she doesn't get arrested or in trouble. What are other ways around distributing these needles so one doesn't have to worry about legal action? And I'm going to couple that with, what advice do y'all have for getting harm reduction resources in my community?
Yeah. So actually at the end of the slide deck, I would just encourage you to go through, let me see if I can just find it for you. There's a resource surrounding all of the policies that exist in each state. And if I didn't include that in here, I will send it to Sydney to share out with the group, but I would be very attuned to the protections in your state before you move forward. Just so that you know, if you do get in trouble, that this is the way you are and aren't protected. That said, there are ways in which you can partner with other providers who have already done this work in other municipalities to be a secondary exchange of that exchange. So maybe their municipality is already secured in their syringe access being legal within their municipal area. You can in most states leverage that existing structure and be a secondary exchange participant. So receiving supplies from them and then doing distribution on their behalf, if that makes sense. So that's one option. Additionally, there are some historical syringe access program processes that I can forward to Sydney as well. But I cannot tell you to go and do a syringe access program in a state where it is not legal on a recorded webinar and tell you you will be safe from legal prosecution. So I will leave it there, but send you additional information. As far as getting additional harm reduction resources, for Sanders' question, if that wasn't part of it, you got to start at the pace of your community and also push them. You got to push them. If you can start with naloxone, knowing that this is almost over the counter at this point through the FDA, that might be a win. But you got to find your champion who has a little bit of power that can leverage somebody else with a little bit of power and make that go through that stream. That said, a lot of organizations start with things like naloxone or fentanyl test strips because they're perceived as lower liability. And so show them that no one's going to get hurt with those things and then expand.
MJ and I like to get people outside of their comfort zone all the time, talking about harm reduction. So
yeah, with any pitch though, you should combine data, a story, and a fiscal analysis, right? So how are they saving money? Whose hearts are involved? And is this working elsewhere?
I think simply by the amount of engagement we've had in the chat, people are so hungry for this information. So I cannot thank the two of you enough. We just continue to see your accolades in the chat. With that, friends, I don't see any other questions and comments. So thank you so much to Brandi and MJ for being with us here today. Reach out to them or myself if you have additional questions about the content or the CRLA or SAFE project. Thank you again, and we hope to see you at a future webinar.
thanks, guys. Have a good day.
Thanks, everyone.